Welcome to Module 5, Partner and Community Engagement Strategies. In this module, we'll focus on how to build trust, collaboration, and sustained involvement throughout the CHA-CHA process. Data and strategy are essential, but without authentic engagement, even the best plans can fall short. This module will show you how to work alongside community members, healthcare partners, and local organizations, not just as informants, but as co-creators of your community's health vision. Let's dive into what effective engagement looks like, how to overcome common challenges, and how to keep momentum going long after your CHIP is published. Community health improvement is not a solo effort. It works best when local health departments bring in the right voices at the right time, in the right ways. Engaging community partners during both the CHA and CHIP processes does a few critical things. It helps you gather richer, more representative data. It increases the legitimacy and community ownership of priorities, and it lays the groundwork for collaborative implementation, not just planning. Partners can include nonprofit organizations, schools, clinics, housing authorities, tribal leaders, and others working on social determinants of health. Early, consistent engagement leads to better results and shared responsibility for moving the plan forward. So why is engagement so important in the CHA and the CHIP? Because meaningful participation builds credibility, uncovers blind spots, and ensures strategies are relevant to the community's real needs. From a technical standpoint, engagement improves your assessment by adding context and qualitative depth to your data. From a relational standpoint, it creates buy-in. When people are involved in defining problems, they're more likely to support the solutions. Engagement is also essential for health equity. When we bring in voices that are typically excluded, like immigrants, people living in poverty, youth, or the LGBTQ positive communities, we move closer to a CHA-CHIP process that serves everyone. And finally, this aligns directly with FAB Domain 4, which emphasizes community engagement in public health practice. To engage effectively, you need to know who's already in the landscape and what they bring to the table. Tools like the engagement map or power grid help you assess both the interest and influence of each stakeholder or partner. Some partners may have high influence but low interest, like funders, or maybe even sometimes hospital systems. Others might be highly interested but less influential, like grassroots organizations or youth groups. Your job is to tailor your outreach and engagement strategies based on each group's position. For example, high interest, high influence, involve them as co-leaders. High influence, low interest, focus on briefings and shared incentives. High interest, low influence, engage them deeply. They're often your best storytellers and champions for equity. This kind of mapping ensures your engagement is not only broad, but strategic. So hospitals are essential partners in community health. And the good news is they're required to do similar work. Under IRS regulations, nonprofit hospitals must conduct a community health needs assessment every 3 years. This overlaps significantly with the CHA-CHIP process used by health departments. Effective collaboration can mean aligning timelines to reduce duplication, sharing data to strengthen both assessments, pooling resources for community meetings, surveys, or reporting. However, common pitfalls include hospitals expecting the health departments to lead the entire process, different definitions of what counts as community engagement, and sometimes no formal agreements to guide the shared work. That's where tools like the CHNA-CHA crosswalk, partner power matrix, and MOU templates come in. These help clarify roles, align priorities, and build trust between the hospitals and their health departments. So focus groups and community meetings are two of the most powerful tools for elevating resident voice in your CHA-CHIP process. They allow you to dive deeper into lived experiences, explore perceptions that quantitative data alone can't explain, build relationships with residents and community leaders. To make these methods effective, keep groups small enough to allow for meaningful discussion. 6 to 10 participants is a good range. Use open-ended, inclusive questions to focus on strengths as well as needs. Offer language support, transportation, maybe childcare, maybe even stipends to reduce participation barriers. Document and summarize the key themes clearly. This shows that people's voices were heard and applied. Most importantly, close the loop. Let participants know how their feedback shaped your priorities. That transparency builds long-term trust and deeper engagement down the road. And equity doesn't happen by accident. It requires intentional outreach and design. Underserved populations, such as immigrant communities, low-income neighborhoods, people experiencing homelessness, or LGBTQ positive residents, often face the biggest health disparities, but are least likely to be included in traditional engagement efforts. To change that, consider strategies like partnering with trusted organizations that already have relationships with specific groups, using culturally appropriate materials and translation services, holding meetings in familiar, accessible locations like libraries, faith centers, or community kitchens, providing stipends or gift cards as a thank you for people's time and expertise, being flexible in your format. Sometimes a one-on-one interview or a photo voice project is more effective than a group session. Engaging underserved populations ensures your assessment reflects your whole community, not just those you typically engage with access to you. So let's take a closer look at how the engagement looks different across urban and rural settings and what lessons we can learn. In urban areas, for example, like Lincoln, large community events and digital surveys are useful because they reach a diverse and tech-connected population. But barriers like time constraints, language, and trust still apply. In rural areas, like much of western Nebraska, engagement often relies on personal relationships. Strategies may include partnering with extension offices or school districts, using local newspapers or radio for outreach, attending existing community events rather than creating new ones. One rural health department successfully used grocery store intercept surveys and small town hall meetings to collect feedback. In an urban setting, a health department co-hosted a community dinner with a local cultural center to bring in immigrant voices. The takeaway, engagement must be adapted to your context, but the principles of equity, access, and respect apply everywhere. And engagement shouldn't stop once the CHA is written or the CHIP is published. The most impactful health improvement plans are built on long-term partnerships and ongoing conversations. To sustain engagement over the long term, establish regular touch points, like quarterly community partner meetings or annual CHA-CHIP updates. Include partners in the implementation, not just planning. Assign roles and co-lead projects. That's where the work groups come in really handy. Recognize contributions. Thank partners publicly and highlight their role in reports or press. That's part of that institutional engagement, also part of those feedback loops. Build into contracts or MOUs expectations for joint monitoring and evaluation. So instead of just a one-time input, formalize that relationship. And use dashboards and newsletters to keep people updated on progress and results. Again, that's that feedback loop, continuous engagement, standing agenda items. Like, it's just so critical to continue reminding them that this work is happening because we all get busy, we all have our day-to-day. So it helps to have people that are following up. And when engagement becomes a routine part of your department's workflow, not just a special project, it builds lasting trust and shared ownership. So let's wrap up what we've covered in this module. Engagement is more than outreach. It's the foundation of a responsive, equitable CHA-CHIP process. We explored how to map and prioritize stakeholders, align with hospital CHNAs to reduce duplication, conduct inclusive focus groups and community meetings, reach underserved populations with culturally relevant strategies, adapt engagement for both urban and rural settings, and sustain those relationships beyond planning and into implementation. When done well, and this was just a primer, honestly, there's so much depth to this, engagement builds community ownership, improves health equity, and transforms your assessment and improvement plans from good to great. So here's some key takeaways, again, from Module 5. Engagement is essential to a successful CHA-CHA process. It improves data quality, builds trust, and lays the foundation for shared actions. Strategic mapping helps you tailor engagement, knowing who has influence, who has interest, and how best to involve them. Hospitals and CHNA stakeholders are natural partners. When timelines and priorities align, you gain efficiency, funding opportunities, and broader reach. Focus groups and community meetings are key tools for elevating resident voice, especially when supported by language access, inclusive design, and closing the feedback loop. Underserved populations must be centered in your outreach. Equity doesn't happen passively. It requires intention and flexibility. And engagement is a long game. Sustainable relationships and shared ownership turn plans into action and keep momentum strong between assessment cycles. These principles don't just support stronger community health, they also align with FAB standards, especially domains 4 and 5. So here's a few steps to help you apply what you've learned. Obviously, please complete the quiz here at the end, and also see these downloadable handouts and tools. I'd suggest you create or revisit your engagement map. Who are your current partners and who's missing? Schedule a listening session or focus group with a population that's underrepresented in your CHA data. Meet with your local hospital partner to explore CHNA alignment, comparing timelines and priorities. And you can never do this too early. Draft or update an MOU to formalize shared engagement goals with key partners. Build a shared calendar for engagement touchpoints, like the CHIP check-ins, dashboard updates, or quarterly meetings. Start small, if that's what you need to do, but always keep building, keep growing. Every conversation you hold is a step towards a stronger and more connected health and public health community. So, coming up in Module 6, we'll shift our focus from external partners to internal resources. The next module covers resource and capacity building for local health departments. You'll learn, I hope, how to make the most of limited staff and funding, ways to build your team's CHA-CHIP skills, and strategies for grant writing, shared services, and sustainable implementation. If engagement is about connection, capacity is about making sure you have the people and infrastructure to act on what you learn. So Module 6 will help you strengthen that foundation. And to support your work beyond this module, we've included the following additional resources: a crosswalk tool, power matrix, focus group guides, engagement planning guide, MOU templates, and some other short readings for your reference.